Sir, good evening, sir. Shall we start the?
Yes, I'm
Yes, sir.
ready. I'm ready.
Very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's scientific webinar. So, topic for the webinar is current trends of the transfusion in obstetrics and gynecology. I kindly request the participants to post their queries in the comment box at the end of the presentation so that we can have a short QA session at the end of the presentation. And now it's time to introduce our eminent speaker for this evening, Dr. ArunMadhabBoruah, sir. Sir is a consultant gynecologist at Sampriti Hospital, Assam. And sir's area of interest are clinical obstetrics, infertility treatment, and endoscopy. Sir has also several honorary titles to his name, including Fellow of Indian College of Obstetricians and Gynecologists and Fellow of Indian College of Maternal and Child Health and a PhD in Alternative Medicine. Sir was the chairman of FDMSC Committee of Federation and Obstetrics and Gynecological Society of India in 2000, in 1999 to 2003. Sir has 17 publications in national and international journals. Sir has also contributed 7 chapters to various textbooks and recent advances and monographs. With this introduction, I would like to welcome you, sir. And sir, before going to the session, we are launching our Shield Connect webpage, sir. So I request you to allow me a 1 minute video
Sure.
regarding our Shield Connect, sir. Chitrakala, and now we can play the video. And Shield Connect is a new initiative of our Shield Healthcare, sir. So it's a digital platform for with all updated informations in women's health, and all our webinars are conducted through our Shield Connect only, sir. And it has blogs, scientific informations related to women's health, and you can find videos of past webinars and informations of upcoming webinars on this page. So I request all the participants to go through our webpage for all updated informations. So thank you, sir. Over to you, sir.
Thank you, Mr. Stalin and the team SEAL Healthcare for this very new way of taking the things forward. And I'm sure everything today is going to be a part of what you are really dreaming for. At the outset, I must offer my gratitude and also a big thank you to your organization for asking me to make a presentation of my choice in today's scientific discussion. As you go ahead with the topic that I have chosen, that's current trends of blood transfusion in obstetrics and gynecology. Before I go into the main subject, I would like to say why I have chosen this particular topic. We always want to be something different from others. As every one of you are aware that Northeast is a very, very dynamic part of our country. We have resources, greeneries, and a nature to welcome all of you. And I'm sure you will oblige to my request and do visit Northeast to give us a boost so that we here at the northeastern part of the country feel very strong amalgamation with the whole of the country in every sphere. Like today, where we have pulled up something impossible in Australia, we also feel that we can do what everyone is doing, or even we can do it better. So the topic that I have chosen has the reference across from our Indian Council of Medical Research to the American College, Royal Australian and New Zealand College, even the Canadian College, and our own federation guidelines. Because we all understand that science today has grown far beyond that we have ever thought of. And we need to have one particular guideline across the globe because it matters to everyone wherever she is. And we cannot really compromise on whether she is from a poor or from a resource healthy state. So, blood has been the river of life, and we in OBGYN are really taking this so honestly that we sometimes fail to offer our services when our reach to this very important component of life is withdrawn or is not available for different reasons. I'm sure we are in a diverse country in which every one of you will agree. Some of us work in a corporate hospital where with a click of a button you can get whatever you want. But at the same time, there are doctors who work in remote peripheral areas where except your clinical skill, nothing really exists, yet you need to offer your best services. So I thought, are we really going to be hampered if we do not have blood in our hand? Can we really optimize our care? Can we really set protocols where we need to use blood transfusion in our routine use? It may not be so easy for me, but it's an honest and sincere effort on my behalf because the place where I am, I do not have access to component therapy even in this era of life. Yet there are areas in my region where even transfusion cannot be arranged with 24 hours notice. So let's see, colleagues and friends, can we really optimize and see how can we really do it? We are not going to compromise on the guidelines. We are not going to compromise on the quality of care. Yet we should be having certain positivity in our approach so that our women do not suffer, yet they get the best out of it. We know the blood usually means hemoglobin, and hemoglobin means iron. Red blood cells contain several hundreds of hemoglobin molecules which really transmit or transport oxygen. And the basic science knowledge, what we all appreciate is we need oxygen, we need water, and we need energy to survive in this era. The oxygen binds to the heme molecule of the hemoglobin, and that's how it is being transferred from one place to the other. Transfusion of blood and blood products should be undertaken only to treat a condition that would lead to significant morbidity or mortality that cannot be prevented or managed effectively by other means. This should be the important dictum while we follow this presentation today. The guidelines are being put forward in the same block the way they are being found. They say that do not transfuse blood if other non-transfusion therapies or observation would be just as effective. Blood transfusion should not be given if other safer non-transfusion alternatives are available. For example, patients with iron deficiency without hemodynamic instability should be given iron therapy and not blood transfusion because they are available. The guidelines also say do not routinely transfuse stable asymptomatic hospitalized patient with a hemoglobin level greater than 7 to 8 grams. So it doesn't mean that if you have a facility at your hand, if your transfusion facility is readily available with you, the patient remaining stable only if the hemoglobin itself is 6, 7 or 8, we should not jump into the transfusion morality immediately. A little amount of information. 1 unit of whole blood or even a packed red blood cell can increase hemoglobin by 1 gram per deciliter in an adult or hematocrit by 3%, provided the hemoglobin of the unit is more than 75%. So routinely they are being given in emergency surgeries, in oncological procedures where there is acute blood loss, but in many occasions we can always make a compromise and say this may not be always necessary. So one of the important triggers where transfusion is required is acute blood loss. The best assessment of the blood is by an experienced clinician. We have different pictorial assessment that can give us a rough idea, but in general, we might have to transfuse after a loss of approximately 1500 milliliter of blood due to various reasons. And this number 1500 is not a small number. We need to have a massive blood loss to have this 30% of our total blood volume loss before we need to recourse ourselves to blood transfusion. Also remember that once normovolumic aim is achieved, then we will have to think of different modality and not transfusion at all. So these are definite transfusion triggers, especially for patients who are acutely unwell, where the use of hemoglobin, that is 70 gram per liter, is a guide for packed RBC transfusion. In cardiovascular disease, we can consider transfusion if it is even less than 80 gram per deciliter. In severe sepsis, traumatic brain injury, or in acute cerebral ischemia, use of hemoglobin could be little considered, but they are not within our domain. We in OBGYN are more prone to have patients with chronic anemia, where we have to maintain hemoglobin to prevent symptoms of oxygen lack. For example, angina, there could be syncope, there could be breathlessness, and there will be obviously tachycardia. So these are more common than acute blood loss following an injury or other non-cardiac causes. So some factors need to be considered before we think of blood transfusion. Carefully consider the decision whether transfusion is required by taking into account the full range of available therapies. And this is where we need to have our knowledge what are the available therapies. Transfusion be prescribed only when it is likely to offer a worthwhile benefit or that the risk of not transfusing is likely to be greater than the risk of transfusing. Allow the patient to make a choice between blood transfusion or non-transfusion interventions such as parenteral iron. We must avoid unnecessary blood transfusion in women with profound anemia as well. So certain recommendations always exist, especially in our discipline. With iron deficiency without anemia, we can always incorporate 30 to 60 milligram of elemental iron for every woman, provided she tolerates it perfectly well. Parenteral iron is also recommended for pregnant women with severe anemia who are hemodynamically stable and yet require rapid restoration of iron stores in second or early third trimester of pregnancy. In maternity patients requiring iron, I think IV iron today is preferred than oral iron because the compliance is better, reactions are minimal, and also the absorption modality is not going to impair the level of iron. So today we have very limited role of blood transfusion, and the indications being to increase oxygen capacity of blood by giving this transfusion, to restore blood volume to maintain effective tissue perfusion following an acute blood loss, and to replace the components where the clotting is in question. We have specific problems in pregnancy. We know that during pregnancy the volume increases by 20%, but the plasma volume increases by 45%. There is a net deficiency of around 15%. So we have to remember this hemodilution in our mind. So during pregnancy, in antepartum period, especially when pregnancy is less than 34 weeks, the indications of blood transfusion are when hemoglobin is less than 5 gram per deciliter with or without signs of cardiac failure or hypoxia. In between 5 to 7, we'll go for transfusion in presence of impending cardiac failure. But when a duration is more than 34 weeks and a hemoglobin is less than 7 gram per deciliter, even without signs of cardiac failure, we'll have to think of blood transfusion, maybe even a component therapy, because we do not have much time till delivery. Also, in the same range, when the pregnancy is more than 34 weeks of gestation, in severe anemia with decompensation, we have to rope in packed cell therapy for improvement of the general condition of the poor lady. Where the anemia is not due to hematinic deficiency, for example in hemoglobinopathy, or where there is a bone marrow failure, we always have to consider a hematologist whether transfusion could bring upon an improvement in the final outcome of the mother and the baby, because they are in a much better position to guide us whether the transfusion will really help or not. In acute hemorrhage, as I said earlier, where there is loss of more than 1500 ml of blood, if the hemoglobin goes beyond 6 gram, there is always a role of transfusion. In intrapartum period, similarly, if the hemoglobin is less than 7 and the patient is in labor, we'll have to take support of transfusion. Otherwise, there is no way we can improve the condition of the mother. Similarly, in the postpartum, anemia with signs of shock or there is an acute blood loss, we need to bring in hemodynamic stability. Yes, we have to recourse ourselves to the help of blood transfusion. But if we optimize this, if we are aware that physiological iron requirements are 3 times higher in pregnancy than in a menstruating woman, we can always build up the iron store during pregnancy or even before pregnancy, and thereby allowing that particular woman to stand the blood loss much better. Definitely, the requirement of transfusion will go down drastically. If you are going into the guidelines, especially the NICE guidelines, which is a very accepted guidelines across the globe, and they are expecting a change in the guidelines, because in this guideline that we are going to bring it to you is from November 2015, and they are bringing in some changes in 2 years time. But till that point of time, we should always ask ourselves, does the patient need transfusion? Is the patient having surgery? If the patient is having surgery, obviously the need of transfusion is going to be considered most appropriately, and we can always think of going ahead. But if not, we need to identify which component of blood the patient is lacking, and we can always make up that particular component, or even transfuse the patient following appropriate recommendation for each of the component, like fresh frozen plasma, platelets, or even red blood cells. We always have to deal with massive obstetric hemorrhage. Every OB/GYN practitioner who has a busy practice, who deals with a huge load of obstetric patient, obviously will come up with 1 or 2 cases of a massive obstetric blood loss, because placenta previa, placenta accreta, likewise are going to be tackled at the level 3 care, and that is where the transfusion will have to come in. But at the same time, as I said just recently, if we anticipate this, if we can read up these patients much before than the time of delivery, we can build up their iron store and allow this patient to stand up this loss to a greater extent than simply correcting their hemoglobin to around 12 or 13. We must optimize this patient's iron health so that they can compensate the loss in a much stronger way. So the causes of obstetric hemorrhage in early pregnancy could be abortions, or even in ectopic pregnancy, which has to be often neglected ones, because today we have access to healthcare by almost everyone in every part of our country. But when it comes to antepartum hemorrhage, I said placenta previa, placental abruption, or even in some cases where there is a traumatic vaginal delivery, we could end up in obstetric hemorrhage. So the approach to iron deficiency anemia in pregnancy and transfusion is very important. In a patient where the hemoglobin is less than 11 gram, we need to look for iron deficiency. Get a simple CBC done. Look at the indices, whether it is normocytic or microcytic or whatever it could be. If we detect an iron deficiency, yes, always we should try to compensate that. But where the hemoglobin is less than 4 gram, I think we need to go for urgent transfusion. Otherwise, this patient will never stand the complications better. So the approach to iron deficiency in pregnancy is very important. This seems to be a busy slide, yet the markers are very simple. 7 gram per deciliter is the cutoff point in every trimester, and we might have to add up ferritin estimation, and whenever ferritin is less than 30, these patients need to be given urgent iron load to compensate and ultimately to make their iron store optimized for subsequent delivery and process. So do not routinely transfuse even platelets for patients with chemotherapy induced thrombocytopenia if platelet count is greater than 10 into 10 to the power 9 per lakh in absence of bleeding. So we never know. The numbers may not really signify the bleeding tendency. We have to be on guard, but it doesn't mean if the numbers are going down, we need to transfuse them immediately. Similarly, do not routinely use plasma or even prothrombin complex concentrate for a non-emergent reversal of vitamin K antagonist. Do not order unnecessary pre-transfusion testing as well. Do not routinely order perioperative autologous or even directed blood collection. Do not transfuse O negative blood except to a O negative patient in emergency for female patients for childbearing potential of unknown blood group. Those dictum that we used should be always remembered, but it is not necessary that we must follow it very religiously. The another very common term that we are learning today is massive transfusion protocol, or what is familiar with OBGYN is an MTP template. What we really do is we optimize oxygenation, we optimize cardiac output, we optimize tissue perfusion, and similarly we maintain the metabolic state. What we do, we monitor every 30 to 60 minutes for full blood count, look for the coagulate screen, look for the ionized calcium or even arterial blood gas composition, whether they are being maintained or not. We always should aim for a body temperature more than 35 degrees centigrade, pH 7.2, base excess of -6, lactate calcium as normal as possible. So by doing this, I think we'll be doing a great justice. And how do we do that? I'll give you certain practice points. If we can remember these practice points, obviously this is going to help us in a great way in utilizing blood and its components for our routine use. Point number 1, in patients with critical bleeding requiring massive transfusion, the following parameters should be measured early and frequently: temperature, acid-base status, ionized calcium, hemoglobin, platelet count, prothrombin time, activated prothrombin time, and fibrinogen level. They must be assessed because they give us an insight what is going on in the patient. Next, values that indicative of critical physiological derangement include temperatures less than 35 degrees centigrade, acid base, that is pH less than 7.2, ionized calcium less than 1.1 millimole per liter, platelet count less than 50,000 per liter, prothrombin time and INR in a subnormal way, and fibrinogen level less than 1 gram per liter. In critically bleeding patients requiring or even anticipated to require massive transfusion, I think then MTP protocol, massive transfusion protocol, should be used and thereby optimize this patient for continuous monitoring and thereby help this patient to survive in a much better way even without requiring the component therapies. In patients with critical bleeding requiring massive transfusion, insufficient evidence was identified to support or refute the use of specific ratios of RBCs to blood component. So practice point 5, in patients with critical bleeding requiring massive transfusion, hemoglobin concentration should be interpreted in the context of hemodynamic status, organ perfusion, and a tissue oxygenation. Point number 6, in patients with critical bleeding requiring massive transfusion, use of RBC and other blood components may be life-saving. However, transfusion of increased volumes of RBC and other blood components may be independently associated with increased mortality or even ARDS. Similarly, we have in patients with critical bleeding requiring massive transfusion, the use of MTP to facilitate timely and appropriate use of RBC and other blood components may reduce the risk of mortality and ARDS. So massive transfusion protocol should include advice on administration of reactive factors 7A when they are really required, when these are very costly and they are not really freely available, but their utilization has to follow this protocol. In practice point number 10, in patients with critical bleeding requiring massive transfusion, suggested doses of components are fresh frozen plasma 15 ml per kg, platelets 1 adult therapeutic dose, cryoprecipitate 3 to 4 gram, or as directed by the hematologist or the transfusion specialist, whosoever is available. We need to activate this massive transfusion protocol. For this activation, So take into account the cause and the rate of hemorrhage, mechanism of injury if we know, current physiological state, and also the likely requirement of ongoing blood component support that are freely available with all of us. So this activation, as I said, will have to include the initial management of bleeding. We need to find out the cause. We need to find out the compensatory measures, surgical recourse that could be required. Specific surgical consideration could also come in. The cell salvage is a possibility, but we do not utilize in our country so regularly, but we can always think of. The doses of different component therapies should be available and should be kept in mind because they might have to be used at random. So coming back, we need to optimize, we need to monitor, and we need to aim for an optimized levels the way we are thinking for. I'll not go into details of all this. This is what we have all discussed. In maternity patients with pre-existing hematological conditions like thrombocytopenia, inherited or acquired disorders of coagulation, we should have their conditions optimized before going to ward and have a multidisciplinary plan available in the place of birth or even in a postnatal period. These patients should preferably be tackled in a tertiary care where we have access to different factors. Today, tranexamic acid is being widely used both for prevention and for therapeutic purposes. Requesting every OBGYN colleague to accept tranexamic acid in a wider way of use so that mode of transfusion are going to be minimized. The component therapy is going to be reduced, but we must use it even in a prophylactic way or even in a therapeutic way. We all know the doses. We need to use 1000 gram diluted in 100 ml of 0.9% normal saline and infuse it over a period of 15 to 20 minutes, both where we anticipate bleeding or where there is actual blood loss. This tranexamic acid, which is freely available across the country, can reduce transfusion to a great extent. There are certain guidelines which are not really set apart, but the expert opinion really counts. In pregnant women at risk of major obstetric hemorrhage, women especially with placenta accreta and major placenta previa, a multidisciplinary management plan should always be strongly advised because when more brains come in, we do more justice to this group of patients. In some cases, we might have to take help of interventional radiology. We know if we can occlude the uterine arteries or even beyond that, we'll be able to minimize blood loss from the uterus or even during an oncological procedure or even in a postpartum hemorrhage. So, where the facility is available, always use this facility because they are much better in comparison to blood transfusion because they have minimized risk. The most common preventable risk relates to errors in identifying patients correctly. Now, why I say this? As I said, the decision to seek blood transfusion or a component therapy is the most vital. So, an important team members need to always come in to decide whether it is really required. Because donated blood is a gift to us and we must use it appropriately. In centers where it is freely available, it doesn't really mean that we should use this in an indiscriminate way. So, today, especially during the pandemic times, we had very difficulty in getting blood and blood components. And that's what I realized. Can we really optimize this? And that was the question why I decided to think it over, study this in details and bring it to every one of you. Yes, there could be time when the blood may not be available. So we need to have a plan B even in absence of blood. So the blood components to be transfused, we all know we do red blood cells. The doses are single unit red blood cell transfusions for adults who do not have active bleeding. Clinically reassess and check hemoglobin if it is required. We can always do that. Fresh frozen plasma is the most important component for any OBGYN practice. We need to have platelets, especially in hypertensive disorders or where there is documented thrombocytopenia or even in severe bleeding. We could require platelet support, but the risk associated with blood transfusion should always be remembered before giving a requisition for blood transfusion. There could be transfusion transmitted infections, immunological sequelae such as red cell ILO immunization, volume overload, fetal hemolytic disease. Transfusion of incurrent blood component is always a possibility and a very dangerous complication of blood transfusion. There could be an acute transfusion reaction, there could be a delayed transfusion reaction, but we should always remember that transfusion reaction is never a healthy complication. We always have tremendous problem in managing transfusion complication. So it is better to think twice before we really go for transfusion. So do we have any alternatives? Yes, oral iron is always a possibility. Pick up early, use it early to see its optimal benefit for a group of women. Intravenous iron is at ready disposal. It is available across the length and breadth of the country. Tranexamic acid, as I said, we need to have more wide acceptance across the fraternity because this is going to be a lifesaver for many of us. Intraoperative cell salvage, we should think of getting in, can be of great help where we do not have access to blood transfusion or in standard blood bank. Patient blood management today has come up in a big way. There are three important pillars: optimization of blood volume and red cell mass of the patient, minimization of blood loss during the surgery, and optimization of the patient's tolerance to anemia. And what is it? We all know this. The goal of patient blood management focuses in improving and converting the patient's own blood, wherein transfusion can be avoided or reduced to prevent related complications and thereby sustain an optimum health of the patient. As I said, a clinical maxim to increase patient safety is patient blood management. If we accept this, we can always practice these three important pillars religiously. It is doable. In summary, unlike before, empirical blood transfusions are no longer the norm. White blood products do have benefit, but they can always cause harm. Consult with a hematologist if they remain unsure about the indications. There is no falling apart or falling same in front of others, but you're preventing a life, preventing a complications. So there is no compromise in that. And the key is to reduce harm from unnecessary blood transfusion that every one of you must have seen during your course of time how a blood transfusion could end up. Avoid administering packed red cells to a young healthy patient with a hemoglobin of more than 7 gram who doesn't have an ongoing blood loss unless the patient is symptomatic or hemodynamically unstable. The evidences exist everywhere. Do not transfuse more units of blood than absolute necessary, noting that many hospitals have developed policies on the indications of transfusion with a view to minimization of blood transfusion because there is strong evidence against blood transfusion today. Third learning point, transfuse red cells for anemia only if the hemoglobin concentration is less than 7 gram or if the patient is hemodynamically unstable or is a significant cardiovascular or respiratory comorbidity. So with this three dictum, I bring an end to this thought process. Can we really minimize blood transfusion in OBGYN practice? Think it over. If you feel that this is doable, this is great. We'll be doing a great benefit to the community and also our profession will be enlightened and remembered for this cause. I'm sure you will think it over and put it to practice henceforth. Thank you. Thanks everyone, those of you who have tuned in, and thanks SEAL Healthcare for bringing me in to share my thought to every one of you. Thank you.
Thank you, sir. Thank you for your wonderful presentations, and it's always a honor hearing you, sir. The key message, take-home message in your presentation is transfusion should be used only when the benefits outweigh the risk, and when there are no other appropriate alternatives are available, and laboratory test alone should not be the sole deciding factor for transfusion, sir.
Right.
Sir, I will read out the questions, if any, in the comment box. Let me wait for 1 or 2 minutes for the participants to post their queries, sir.
Sure.
Sir, I have one personal question. Like when you are talking about this transfusion transmitted diseases, so what are all the transmission transmitted diseases, and what are the preventive measures to overcome these diseases, sir?
As I said, the best way to prevent is to avoid transmission altogether. We can always have errors everywhere. So once we know that HIV became so dangerous through blood transfusion, especially the thalassomic patient, the oncological patient, they had this infection transmitted. Hepatitis B, they are directly related to these transmission errors. Likewise, even malaria could be transmitted. So we have a long list of possibilities that could come in to a person who was really free from all this disease. Yes, today before a transfusion is being organized, we need to rule out all these testings. But always remember, avoiding transfusion altogether is always a better procedure, because there will be no chance at all of getting them into your body if you do not take transfusion at all. But obviously, if you really need them, there is no choice. We'll have to go to the best possible guidelines and get them in for our own health and our own safety.
Yes, sir. Sir, one more question is like, will the blood transfusion cause the affects the immune system, sir, and what will be the outcomes when if it
Definitely,
affects?
definitely, the immune system has got a huge role to play in blood transfusion. When we were students, we have a thought process being put into our cells that only the donors of your own relatives should be the donors. No one else should be the donors. But today, the concept is totally opposite. If you are taking a donation from your close relative, you are having every possibility of immune reaction, and you should never encourage blood donation or even a component donation from your own family members, because your immunity is so compromised, your immune suppression becomes so obvious that you end up with other susceptible conditions than the benefit of taking a donation from your own near and dear ones. Similarly, when there is an immune suppression that comes in following a transfusion, I think we all are in a higher degree of susceptibility, and that is why getting a transfusion going on without definite indication, without a real indication, should never be encouraged.
Thank you, sir. Mm. Sir, I could not find any other questions in the chat box, sir. So, if you allow us, then we can end this webinar for today, sir.
Yes, yes, sure. Thank you so much. And thank you for giving me this opportunity to be with you this evening. I'm sure this can enlighten someone, if not all, because the topic may not be so catchy like other topics. But I thought when I make it my own thought process, because when I was being requested, I was given a responsibility that you have to present of.
Yes, sir.
Thank
Thank
you.
you very much for your presence and spending your valuable time with us, sir. On behalf of Shield Healthcare, I would like to thank all the delegates for their patient listening. There are more than 120, 130 participants joined us today, sir. So thank you, one and all,
Thank
and
you.
thank you for the time, and have a nice day.
Thank you. Thank you so much.
Thank you, sir.
Thank you.